Thank you so much. Welcome to our Mason Lecture. It is my honor to introduce our annual Mason Lecturer, Dr. Philip Schauer. Dr. Schauer really needs no introduction to this audience, as he has served ASMBS as past president and has been a very visible leader in our specialty for many years. His accomplishments are too numerous to recount here, but he has built internationally recognized programs at the University of Pittsburgh and then at the Cleveland Clinic. I know he is very proud of his newest appointment as professor of metabolic surgery at Pennington Biomedical Research Center and Louisiana State University. And one of the reasons that he is proud is he tells me he believes he may be the first professor of metabolic surgery in the United States. Of course, Phil was instrumental in changing the name of our organization to include metabolic surgery when he was ASMBS president. I and many others learned laparoscopic gastric bypass from Phil during his outstanding courses at Pittsburgh back in the late 1990s. He is a true pioneer also in the area we've asked him to discuss today, metabolic surgery for diabetes. We could not have a more worthy or qualified speaker on this topic, as our meeting focuses on the theme of diabetes this year. Please join me in welcoming Dr. Schauer to the stage to present our annual Mason Lecture.
Thank you, Eric, so much. It is such an honor to be here today and speak in front of this group. And it was exactly about 12 years ago, some of you in the audience may remember this, was the last time I spoke to this group, and my slides exploded, if you recall that. It was the most embarrassing moment of my entire life, and it took about 45 minutes to get the slides working again, and you people waited for me and gave up your lunch for my lecture. So I really hope and pray that it works. I just tested them, so I think they're going to work okay. Okay? So, as Eric said, I actually have a new home now. I've moved to the Pennington Biomedical Research Center. It's a phenomenal place. It's one of the world's most renowned obesity metabolic research centers, and I invite all of you to come. Here's our incredible campus, which is really world-class. But what's even more world-class than our campus is this outstanding, distinguished faculty who are legendary, from George Bray, Claude Bouchard, Eric Ravison, Donna Ryan, and the new executive director, who's been my friend and colleague for over 15 years, Dr. John Kerwin. So I can't think of a more exciting place to spend the rest of my career. And frankly, folks, it is my dream job. So these are my disclosures. I think none of these have any particular conflict with the presentation today. And I have to say it is extraordinarily an honor to speak at Obesity Week, and especially this year with the theme, being diabetes. It's an incredible honor. But, I have to say I'm a bit saddened that Obesity Week will no longer exist after 2019. And I'll mention a few things about that at the end of my presentation. Now, Dr. Ed Mason is essentially the father of bariatric surgery, and again, what an honor and privilege it is to deliver the address in his name. And I understand that Dr. Mason is 99 years old and going strong. And did you know 2019 is the 50th anniversary of many things? The moonwalk, Woodstock, Abbey Road, Beatles album, right? It's also the 50th anniversary of the Mason gastric bypass, published in 1969. So how appropriate that I had this opportunity to give the Mason Lecture on the 50th anniversary of the gastric bypass, which is one of the most dominant bariatric procedures in the world. Now, I wanted to acknowledge and actually dedicate my presentation today to a very good friend of mine and friend of the BMI at Cleveland Clinic, Mr. Al Swope. Al was the heart and soul of our program at the Cleveland Clinic. He was an administrator who had an incredible heart for his patients. As you can see, he himself struggled with this deadly disease. And unfortunately, just a few weeks ago, he passed away suddenly. And he was a tremendous guy. He was very involved with ASMBS. This is a picture of him last year at the Ohio chapter, that big chapter meeting last year. He was so proud of his involvement. So I want to dedicate this presentation to my good friend Al Swope. So what I'm going to talk about over the next few minutes, I think are some really, really important questions of our field that have yet to be answered. These questions relate to, does weight loss really reduce morbidity and mortality? What's the current evidence? Why is an RCT so helpful? What are the arguments against performing a multi-center RCT? What does an RCT look like? Let's do it. I need your help. So I'm going to start where my friend and colleague and mentor Steve Nissen left off last year at the Obesity Week keynote address. If you were there, you remember he talked about the relationship between obesity and cardiovascular disease, how obesity was the major driver. And this is what one of his concluding statements was. He says, what we needed now is a cardiovascular outcome trial for metabolic surgery, because it is the one treatment of obesity that has perhaps the greatest chance to actually show a mortality benefit. So I'm going to ask you, do we have some Twitter people in the audience? I think we might have one or two, okay? So I'm going to ask you a question, and we just released it on Twitter, but save your answer till I finish this presentation. I'm going to ask you this question. Is a multi-center randomized controlled trial for metabolic surgery with clinical endpoints, is it recommended? Yes or no? And tell us why or why not. And to get access to this, just find me on Twitter, @PSchauerMD. It'll be there. It'll be up for 7 days. So I'm very curious to know what our community thinks about this question. Early this summer, in fact, in June, the Wall Street Journal had this really provocative article about cardiovascular disease and how the last half century made tremendous benefits in terms of reducing cardiovascular mortality through smoking cessation, statins, and many other things. But if you look at the last 15 years, as shown here, the benefits have stalled. There's been really no improvement in reduction in cardiovascular disease. Why is that? Well, the article goes on to point out that the most probable explanation is the rise of obesity and type 2 diabetes, and the fact that we, as of yet, don't have effective therapies, or thought to be effective therapies, for obesity and type 2 diabetes. And for this reason, the benefits, the improvements have actually stalled. It used to be thought that by the turn of the century, the last century, that cardiovascular disease would no longer be the number one cause of death in the U.S. It would actually drop below cancer. But as you can see, it's stalled. So how are we going to actually continue to improve cardiovascular death reduction without addressing obesity and diabetes more effectively? So we all know obesity and diabetes are extremely lethal diseases. And in fact, with respect to obesity, the higher the degree of obesity, the higher the risk of overall mortality. And all of you know this. And the same goes true with type 2 diabetes. So these two important, I think, the most fundamental questions of our time are as follows. Number one, does metabolic surgery reduce cardiovascular morbidity and mortality? Now, I know some of you think we've already answered that question. Maybe, maybe not. Number two, and this one's even more fundamental than surgery, does intentional weight loss by any means reduce cardiovascular morbidity and mortality? We don't have the answer to that just yet. You think we would, because isn't it true every therapy for obesity is principally based on losing weight? It might cause health benefits, but does it actually reduce mortality? So, The vehicle that is most effective to answer this question is called the cardiovascular outcome trial, and it's a randomized controlled trial, but with specific cardiovascular clinical endpoints, such as heart attack, stroke, death, revascularization, amputation. And there's some others that can be considered here. This is different than a marker like A1C or blood pressure or a lab value. These are actually events that humans are really concerned about. So I'm going to quickly review the literature for cardiovascular outcome trials for weight loss interventions. This will be pretty quick because there's one. There's only one in the entire history of obesity research. It's called the Look-Ahead trial. Many of you are very familiar with this. It's a very well done study. Patients were randomized to intensive lifestyle intervention versus sort of usual care therapy with education. And after 10 years of this, the group that had the intensive lifestyle intervention, and some of these also had weight loss drugs, lost 6 kilograms at a starting of about 101, 102 kilograms, which is about a 6% body weight loss total. Okay? So, it had absolutely no effect on overall mortality, 0. And the conclusion was that this was essentially a negative study, that a weight loss over 10 years of 6% body weight just doesn't cut it. Okay? Which brings up, it doesn't end the question, or doesn't resolve the question, does weight loss reduce morbidity or mortality? I think what it says is we need more weight loss. So perhaps greater, longer sustained weight loss is necessary to produce this mortality benefit. But this question is not answered. Now, to be fair, there are other cardiovascular outcomes trials in the obesity diabetes world, especially with these new drugs. But these drugs might cause a little bit of weight loss. They improve blood sugar control. They may have anti-inflammatory mechanisms that account for the mortality. We don't really know, but they are proven with cardiovascular outcome trials that these SGLT2 inhibitors and GLP-1s actually reduce mortality of obesity and diabetes by a small amount, 10%, maybe 15% range, but they're proven. So our colleagues in endocrinology and cardiology can say they have proven therapies. Do we have proven therapies? But the promise is very good for surgery. Look, medical weight loss can produce about 6% body weight, and some of the newer drugs might actually do a little better than that. Will it be sustained over 10 years? We'll have to see. But we have pretty good observational data that surgery can lead to 20-25% body weight loss that's sustained for 10 years and even longer. So let's review the literature of cardiovascular outcome trials for metabolic surgery. This will be really quick. 0. We got 0, folks. We got no clear, proven evidence. Okay? Now, we have an abundance of observational studies. In fact, there's actually more than 20 where we compare surgery to non-operated controls. These are mostly retrospective studies. The one that's closest to a randomized controlled trial is the SOS study. It was prospective, but they weren't randomized. Okay? So it's really an observational study. But there's a large degree of consistency. In fact, all of them show mortality reduction with metabolic surgery compared to the control, and a pretty significant impact or size effect, 30 to 90% reduction, on average about 40-45% reduction in mortality, which is enormous compared to what pills can do. The most recent observational study is conducted by my colleague, Aliyah Minion, and our team at Cleveland Clinic, looking at about 2,500 patients over the last 15 years, basically my entire career at Cleveland Clinic, who had diabetes, who had metabolic surgery, compared to nearly 12,000 patients who were matched. It was a 5-to-1 match. So we had a really nice sample size to address this issue. But mind you, it's an observational study. And this is what we found. This was published in JAMA just a couple months ago. That the 6-component MACE, which is death, heart attack, stroke, revascularization, and heart failure, surgery dramatically reduced those events by a significant hazard ratio of 0.61, which means almost a 40% reduction, which is really huge. And when you look at the three-component MACE, which is heart attack, stroke, and death, very, very similar, huge effect, okay, in a relatively short amount of time. So this is very promising. And when you look at all the endpoints we looked at, you see very significant reductions there favoring surgery, okay? If you operate on 13 patients, you'll save a life. That's a pretty good ratio, actually, okay? But, these are observational studies, okay? If you look at the conclusion, look at the very last sentence. This is JAMA, okay, one of the highest impact journals in the land. The findings from this observational study must be confirmed in a randomized controlled trial. There you go. Now, do we have randomized controlled trials in metabolic surgery? Yes, we have 12. Really good studies, actually. But these are studies that looked at diabetes control or blood sugar control, a surrogate marker. They weren't large enough to look at these event rates of heart attack, stroke, and death, but they were all quite consistent in showing surgery superior to medical therapy. Even the largest study, a Stampede trial, which we conducted in Cleveland, wasn't large enough to actually show these events. And even if we follow these patients a lot longer, it's still not going to probably be long enough to show that a mortality benefit. Okay. Now, in an effort to try to achieve that with some of these trials, the NIH has supported the ARM study, which is a collection of 4 of these studies from Pittsburgh, Anita Corkelis and her group, University of Washington, David Cummings, David Arterburn, in Boston, Mary Elizabeth Patty, Don Simonson, and Ashley Vernon, and then the Cleveland group, myself and Sangeeta Kashyap, and John Kerwin is the co-PI of this study. So that'll double the numbers, but the likelihood of us showing a mortality benefit is probably low. So, is the data that I've showed you so far compelling? It's fairly compelling data. The real question, is it enough? I say it's not enough. Not quite enough. We deserve more. Now, let me just share with you a really nice editorial by one of my main mentors, Steve Nissen. He talks about the limitations of observational studies and the strengths of randomized controlled trials. An RCT is the most reliable source of evidence. An RCT can leverage the power of randomization to ensure that alternative therapies are studied in populations with similar characteristics, even characteristics you don't know about that might be important, because the odds are that they'll be equal in both groups because of the randomization process. Observational studies do not prove causation or effect. They are useful for generating hypotheses and for new trials, or they can show associations, but they do not show cause and effect. And here's an interesting table that's right out of Dr. Nissen's editorial. I think anybody doing a trial should really read this. The strengths of an RCT, much higher quality of evidence, allows for precise control of the intervention, the power of randomization. Some studies allow blinding for patients and physicians. It's hard to do that in a surgical trial. That also further reduces bias. And it's accepted by regulatory authorities, the people that are going to pay for these surgeries, right? But there are weaknesses. They're expensive. They're hard to do. They're challenging. Observational studies are easier to do. They're lower cost. You can get big numbers, but it's a much lower quality of evidence, and they're subject to bias, and they do not prove causation. So these are some of the problems with observational studies we have to keep in mind when we interpret these studies, even ones that look very promising. And also with observational studies, there's this problem with post hoc analysis bias, that you get this big data set, you're looking at things retrospectively, you look at the data first, and then you put your methodologies of statistics after you've been biased by the data. And even the best intended investigators can sometimes not avoid bias in their studies. So big data is the big thing now. It's the new big thing, right? But big data is often and can be bad data. Let me give you one really good classic example, and there are lots. This is the estrogen story, okay? So in the early 1990s, there was a big meta-analysis of many observational studies about estrogen. And this meta-analysis suggested that estrogen reduces cardiovascular disease, heart attacks, and strokes, and reduces hip fractures, slightly increases breast cancer, increases endometrial cancer, but if you give progestin, it can counteract the endometrial cancer problem or a hysterectomy. So they concluded that estrogen was recommended for women, particularly postmenopausal women, to prevent heart attack and stroke based on this observational study. Here's some of the data, numbers and numbers of studies. And if you pool the analysis, you see a hazard ratio of 0.65, which means 35% reduction of cardiovascular mortality with estrogen. Wow. So what happened? All throughout the 1990s, millions of women were treated with estrogen and progestin, thinking that that was going to reduce the risk of heart attack and stroke. 2002, a definitive randomized controlled trial was performed. Almost 17,000 women were randomized to estrogen and progestin versus placebo. They had to stop the trial early because of a high risk of breast cancer was emerging in the data. And they also found that estrogen and progestin actually was associated with an increased risk of cardiovascular events, strokes, and PEs. But there's no difference in overall mortality, though. And their conclusion was that the risk of estrogen and progestin exceeded the benefits. The benefits in hip fractures and potential, reduction in cardiac events. And here's some of the data here. Higher risk with estrogen of cardiovascular events. Well, you can read it yourself here. And only with colorectal cancer was there a slight benefit, for reasons that are not quite clear, and hip fracture. But when you add it up together, women were worse off having estrogen and progestin as opposed to nothing at all, completely reversing this large observational multi-center study that was published a decade before. So what happened? Why did the observational study fail? Well, it failed to identify or recognize that women who got estrogen were more health conscious, exercised more, and consumed more heart-healthy diets. That's why they did better. It had nothing to do with the estrogen. So it's a confounding factor, and that's the problem with observational studies. Okay? So why bother with observational studies? Well, they do have merit, okay? We live in a real world, and you can't do an RCT on every single intervention, right? And next to an RCT, a well-done observational study is the next best thing. But it does have limitations, okay? Now, are you convinced yet that we must have a CVOT for metabolic surgery? Some of you are thinking, not so fast, Schauer. What about the challenges of this study, of doing a big multi-center RCT? A lot of challenges. They're too expensive. That's one argument. They take too long. Unethical. There's no equipoise. If we already know the answer, how could we subject patients to not getting surgery if we know that surgery reduces mortality? And logistically challenging to do these studies, especially when you're comparing a surgical intervention with pills versus just comparing pill X with pill Y. Much more challenging to do. But are they possible to do? Yeah, they're possible to do, okay? So let me counter this argument that they're too expensive. I say, relative to what, okay? Now, it is true that they're expensive. And this type of trial will cost tens of millions, maybe even $50 million. That's a lot of money, right? The average NIH R01 is 1 or 2 million. So is one of these trials worth 50 R01s? I don't know. But look at it from this perspective. The U.S. spends about $7 billion a year on metabolic surgery. $50 million is less than 1% of what the U.S. spends 1 year for metabolic surgery. In fact, it's about $200 per case. So that's the cost of one staple cartridge. So if everybody across the country just took one staple cartridge per case, put that into a piggy bank, we can pay for this study. Okay? Another perspective. 50 million is a teeny weeny, itsy bitsy piece of what we're spending 300 billion in ineffectively treating diabetes and obesity. That's 0.017% of 300 billion. It's nothing, okay? And yet today, we can't say definitively that metabolic surgery reduces mortality. Okay? So is it really too expensive when you consider it that way? Now, outside our field, the cardiovascular world, there have been hundreds of cardiovascular outcome trials with other surgical procedures: coronary bypass surgery, carotid endarterectomy, abdominal aortic aneurysm, vascular stents, peripheral vascular surgery, LVADs. In fact, that's why these operations are being done, to prevent cardiovascular death from heart disease, right? So that's required. Now, let me just give an example. So let me go back to how many cardiovascular outcome trials for our field? 0. This is just coronary bypass alone. This is a really cool meta-analysis review in British Medical Journal just a few years ago. Over 100 studies on coronary artery bypass graft alone, comparing it to medical therapy and various other interventions like stents, bare metal stents, drug-eluting stents, and so forth. Going back to the 70s, hundreds of thousands of patients have been randomized to coronary bypass versus some other medical treatment or non-surgical treatment. It can be done, folks. And this is what they showed: a good but modest reduction in mortality, 10 to 15%, and that's stretching it a little bit, actually, okay? But that operation can have an impact on cardiac disease. But how does that compare to our observational studies, which suggest that metabolic surgery is even greater, 40, 50% reduction? But we haven't proven it yet. Let's compare coronary bypass with metabolic surgery. It's an expensive operation, $80,000 to $100,000. There's 600,000 of those being done per year, compared to 240,000 metabolic surgery. Return on investment for coronary artery bypass, you'll never see a return on investment. There's some studies show with our procedure, you get a return on your investment in 10 years. The morbidity of a coronary bypass and the mortality are 10 times greater than metabolic surgery, based on our observational data. But they can say that they can actually prove there is a mortality reduction. Our observational studies suggest 35 to 50% reduction, but we can't prove it. We haven't proven it yet. 100 cardiovascular outcome trials for CABG, 0 metabolic surgery. So it often comes down to, is the question important enough? The people at NIH and the people that have the money to do these trials have to make these decisions. Is it important enough? Well, let me ask you this. The basis of all treatment for obesity is weight reduction, right? Should we not answer this fundamental question? Does weight loss reduce mortality of obesity? I think we should answer it. And further, can metabolic surgery actually help us get back into reducing the cause of death, or the number one cause of death in our country, cardiovascular disease? I think the answer would be yes. Now, who agrees with me? Who thinks there should be a cardiovascular outcome trial for metabolic surgery? Well, let's ask some non-surgeons. And I think you'll find that the vast majority of non-surgeons, I have a list of some people you might recognize, okay, that think we should do this. Steve Nissen, who was our keynote speaker last year. Will Cephalou, who gave the keynote speaker this year. Some prominent cardiologists: Deepak Bhatt, Mike Farku, Bob Eckel, president-elect of ADA. David Nathan, one of the greatest trialists in diabetes, thinks we should do this. Ralph DeFronzo, Gilles Trudman-Grone. I mean, you can read for yourself. These are all prominent leaders. They all think we should do this. We need to do this, okay? What about our surgeons? Professor Porres, Buchwald. The list goes on and on and on, okay? And these are, and please forgive me, many more people should be on this list. I may have left out, okay? But many of our prominent thinkers in our field think that we should do this, okay? Are there some naysayers? Yes. An hour ago, I got off the phone with my good friend Harvey Sugarman. And Harvey and John Crowell, the late John Crowell, God rest his soul, John passed away in May. They wrote an editorial a couple years ago in Sword saying that they didn't quite think there's equipoise. They think that the observational studies are good enough. So I do respect their opinion on that. But I think the majority of people in our field think that we should do this. Now, we're also going to be seeking endorsement by organizations, the ADA, American Heart Association, the Obesity Society, ASMBS, American College of Surgeons, industry, and other people, because these decisions are made when there's enough of a consensus that we should do this. That's what drives the decision for a yes. And I'll be asking ASMBS, and hopefully many of you will support me at encouraging our leadership to support this notion. Okay? Now, so this is the Twitter poll. So I do want all of you who are on Twitter, at some point, maybe today, at least in the next 7 days, please tell me what you think. Do we really need this study? Yes or no? And please indicate why or why not in your response. Okay? This is what a trial might look like, okay, in my final few minutes here. This is what I would call my dream trial. Okay? In fact, that's what I'm calling my trial. Diabetes reduces effectively after metabolic surgery. Dreams. You like that? Henry, you like that? Good. Henry gives me a thumbs up. Okay. This is what it looks like, though. Okay, we need about 2,500 patients with obesity and diabetes and cardiovascular disease. The primary endpoint will be a clinical endpoint, a MACE, heart attack, stroke, or death. It looks something like this. Patients will be randomized to medical therapy or surgery, the two most common operations, bypass and sleeve, and we'll follow them over 5 years. And based on predictive event rates, about 5% per year, over a 5 to 7 year time period, we should be able to see a difference between medical and surgical therapy if surgery can reduce mortality or heart attack or stroke. And we need about 70 centers to be involved with this. Do you want to be involved? Well, if you want to be involved, this is what we need. And I'm trying to advance the slide, and it's not advancing. Let me try this. Here we go. Site criteria: you need to be a MBSA-equipped center of excellence, share your outcomes, you need to have decent volume, you need to do these operations, obviously. You need to have good cardiology, endocrinology support, and having trial experience would be very helpful, okay? Now, if you want to know more about this, today, 5 to 6 p.m. in Lagoon H, we're going to have an informal seminar to discuss this. So if you want to be interested in participating, because we need 70 sites, we can talk to you more about what this might entail. Okay? So finally, I just want to conclude that I think we're on the brink of a great opportunity. Over the last 2 decades, we've built up our evidence base to the point that we can say we have sufficient evidence to say that, yes, it does make sense to do a cardiovascular outcome trial for type 2 diabetes. Okay? Now, finally, I'm just going to sadly say that I'm sad that Obesity Week will no longer exist in the present form. And I'm going to give you my thoughts. As one of the founders, one of the individuals who thought this would be a good idea, I personally think it's the greatest obesity meeting in the world. I'm not the only one. We have some of the best speakers. You've heard some of the keynote speakers in the past, and in this session in particular. Some of the best presentations, best of the best science, very diverse array of topics that spread across obesity, public health, basic science, clinical science, epidemiology is here. Not always perfect, always ways to improve it, and the relationships between the organizations that run this. But people vote with their feet. This year was a record turnout, 5,800. Last year was a record. We're on a trend. So why would we end it if we're on a trend? So tell me what your thoughts are. This is a Twitter poll. This will be released very shortly. You have 7 days. Obesity Week after 2019 will no longer exist as a joint meeting with ASMBS and TOS. Do you favor splitting up Obesity Week? Tell us what you think, because you should have a voice. So finally, I think I'll end there. I really appreciate your attention, and hopefully I've convinced you at least that we really ought to think carefully about doing a cardiovascular outcome trial, because I think it's the one thing we need to push our field forward. Thank you very much. Thank you. Sorry, I took 2 extra minutes. You okay? Oh, I get a plaque.
Phil, it's my pleasure to give you this plaque recognizing your Mason Founders Lecture, and we appreciate your presentation very much. Thank you.
Thank you, Eric. Thank you very much. It's an honor. Go get him, Tiger. Thank you.